Good morning, students. So far, we have covered very few chapters. Means very though they are very few, very important chapters, especially about fever. What is meant by fever? Means definition, its types of fever, and fever of unknown origin, and fever associated with skin lesions. Similarly, today we are going to discuss another interesting one. It is common complaint that brings patients to us. Though it is very common, sometimes it is perplexing also. Since childhood, especially in pediatric age group, parents often become anxious after their child has that complaint for especially for more than one day, rushing in anxiety to pediatrician, or as an adults after 5 days or so, especially associated fever. It is cough. Actually, cough is a protective mechanism. Cough is a reflex mechanism which is initiated by noxious stimuli, either exogenous or endogenous. Exogenous means air pollution, pollen, or smoke, kind of those things, and also endogenous stimuli, especially those are related to our respiratory tract. Sometimes our immune system goes haywire, it may produce this complaint. Anything right from the nose till GA tract can produce this complaint. So, whenever a person coughs, what happens physiologically is that, especially because there is a corrosion of glottis, there is enormous accumulation of pressure inside the thoracic cavity, even reaching up to 300 millimeters of mercury, much above than that what we usually breathe. Okay, got the point? This is the thing I am going to tell. First one, in your plus 2 means intermediate level, you might have come across this formula. E is equal to half mv square. So this is about kinetic energy. Energy is equal to half m. I am not going to discuss entire physics. M is mass, v is velocity. So whenever there is increase in velocity, it is going to have exponential increase as far as energy is concerned. Means if velocity is doubled, energy becomes quadrupled, means 4 times. So this amount of velocity, it is produced by partial glottic obstruction. Got the point? It is especially accentuated by this mass. What is this mass? Entire intrathoracic cavity along with the secretions. This half is constant that we are now going to discuss. I am not entering a physics lecture. So when such amount of velocity is produced, definitely there will be exponential increase in the kinetic energy or work that expels the whatever contents are there. It might be sputum, it might be foreign body, whatever it is there. This is a neuroprotective mechanism. So how it happens? God has created few channels which are essential for production of cough. On right hand side you can see A delta fibers and C fibers. A delta fibers are very thin myelinated fibers. Thin means very small diameter, myelinated. Whereas C is essentially unmyelinated fibers. Unmyelinated fibers. Got the point? So all these nerve fibers, they traverse through our largest cranial nerve, that is 10th cranial nerve, vagus, and these impulses reach brainstem. Remember this point. This cough is voluntarily controlled by our cortical centers. So cortex integrates this cough impulse. Okay. So anywhere in this pathway, why this is relevant? Because behavioral modifications, pharmacological agents, they are going to be effective in this tract right from here to here. A delta fibers, C unmyelinated fibers, vagus nerve, brain stem, and higher cortical centers. Okay. So let's move towards our left side. At the end of these fibers, we have got a few receptors. What are they? One is transient receptor potential channels, TRPs. Second one is purine, that is purine means ATP related P2X3 channels. Coming to TRPVs, there are 6 types of these channels. As far as respiratory system, type 1 and type 2 are important. Type 1 is classical, that is transient receptor vanilloid. What is this vanilloid? Vanilloid is nothing but this is actually capsaicin related. Capsaicin is nothing but active constituents of our irritating substances from chili family, which can irritate these nerve endings, not only for lungs, at the level of skin, kind of those things, GA tract, heart, and their response to heat also. So full name is transient receptor potential vanilloid channels, TRPV. So this vanilloid moiety is a part of capsaicin molecule. So when this compound binds to this channel, it is going to stimulate production of a substance known as substance P. This substance P is going to stimulate these nerve endings, either A delta or C, then impulse will be transmitted to brainstem and the cortex, integrated, and afferent comes back. So cough is produced. So in this way, afferent and afferent limbs of cough are essential and should be synchronized for a effective cough. Abnormality anywhere, either at the level of lungs themselves or thoracic case, like its muscles or abdominal musculature or nervous system, even heart dysfunction can lead to ineffective cough. So hope it is clear. So far we have discussed cough, origin of cough, the receptors involved, the neurotransmitter involved, and nerve fibers involved. Actually, if you take these channels, TRP and P2X3, where these channels are, they are actually upon these famous J receptors. J receptors. So if you have read the physiology thoroughly, by this time you might be knowing where they are located. What is meant by J? Juxtacapillary receptors of the lung. Juxta, just aside or aside the capillaries in the lung parenchyma. So juxtacapillary receptors. So these noxious stimuli through these channels on juxtacapillary receptors, they produce substance P, and through these pathways it is going to stimulate these higher brain structures. Let's go to next slide. So what is this substance P? You know anything about Euler, a Swedish physiologist, and Gadum from UK? Almost a century ago, these two have done research at London in 1930s, 31. They found out this substance. they isolated this chemical, that is substance, from the brains and intestines of horses, and they saw that the action of this substance is smooth muscle contraction, and it was very difficult to isolate and to store at room temperature, so they crystallized it in the form of a powder to store. So here P stands for powder, just that is the thing. Actually substance P stands for powder, but it left like that for next 40 years until Dr. Susan Lehman found out that the same substance P is responsible neurotransmitter for pain. Pain is one of the cardinal or distressing complaints of any human being. So pain. Serendipitously, the P also we can anchor it for this P. So substance P originally means powder. Later we are attributing this to pain. Okay, this is a little bit about history of substance P. The substance P, in addition, now we have seen its action in the propagation of nerve impulse from the J receptors to the brainstem. On the way, because the substance P is produced in the dorsal root ganglion cells, either it can travel peripherally or centrally. So peripherally, these nerve fibers, J receptors, whereas in central, it is going to synapse with other central neurons. Here it acts upon the NK receptors, NK or. So here it is J receptor peripherally, central it is NK receptor. Got the point? So that is about substance P, a short note. Let's go to next slide. This is often asked question in our clinical rounds, right from third semester. Nowadays we are calling it second year, and especially this is a favorite question for old timers, for professors from 1980s and 70s. In initial days, acute cough has been defined up to 1 month, but later it has been revised with advent of science, because many things have been found out. So they have revised it down to 3 weeks from 1995. The original duration of acute cough was 4 weeks, means 1 month, but now it is 3 weeks or less than that. That's it. Subacute means from original 1 month to second month, but now it is from third week to second month. This is subacute cough. You need not remember these things. You not try to memorize. Just with experience and common sense, we can remember. So any cough lasting for more than 2 months, that is 8 weeks, is known as chronic cough. Got the point? This is one of the very important slides, right from second year till final year also, sometimes even for MD internal medicine also, it is very important. Okay? But this classification is not watertight. It is just arbitrary classification. If you see, majority of the causes of subacute cough, that means persisting into second month, or prolonged episodes of which produce acute cough, like usual viral febrile illnesses, other noxious stimuli like environmental pollution, kind of those things. Okay. So let's go to next slide. Because discussion of chronic cough especially clears our, we can say, clinical acumen about how to approach a patient with cough. So chronic cough definition, you are clear. Anything more than 2 months, that is 8 weeks, is known as chronic cough. So how to approach a patient with chronic cough? First one, again most important, is proper history. So is there any history of fever, cold, nasal discharge, any skin rash, kind of those things you have to ask. And also succinct means thorough physical examination you have to do. Of course, you are going to auscultate lungs, but respiratory system deserves much more attention than that. Nowadays, because of either culture stigma, all these things, people are forgetting inspection. Inspection means undress the patient at least at the level of thorax, examine respiratory movements thoroughly, any abnormalities of rib cage or any skin lesions you can assess. Okay. Next one is palpation. Palpation of thoracic case for any abnormalities or other stimulated ones like vocal phragmitis, kind of those things I'm not going to discuss. We will have separate class for those things. Palpation, percussion. We have to look for any consolidation or any fluid accumulation that we call it as pleural effusion or empyema depending upon the etiology, and auscultation. This is the classical examination. But there are few theories that if you are doing a palpation, percussion, sometimes you may produce a surreptitious, means artificial sounds while auscultating. So nowadays there is a school of theory that auscultation has to be done after inspection. Then you can go ahead with the palpation and percussion. Whatever it is there, it depends upon your professor's choice. If you are a student and want to pass that exam, just follow his fancies. That's it. There is no thorough, hard and fast rule as far as physical examination is concerned, but be thorough in your examination, whichever way you take. It is just like traveling to another place. If you got two routes, if Google Maps suggests a good route, you shouldn't blindly follow that. If it insists to follow that, sometimes that road may be full of pebbles or it might be blocked. So always have option B. Coming to physical examination part, these are the other areas most often we forget to examine. Nowadays, MBBS students are not carrying otoscope. That is one of the gross mistakes we are doing. So always have a otoscope, small otoscope. For 3 or 4,000 you will get. One nasal speculum, a torchlight. it will pay for your success in long run, because nowadays what matters at the end of the day is your thoroughness with the patient, not simply passing exams with gold medals or getting marks. When you are applying knowledge practically, that means bedside, then only you will be a successful doctor. Otherwise, it will become just another clerkship. So what I mean is that whenever you are with patient, be thorough with him or her as far as history and physical examination concerned. Unfortunately, nowadays we are seeing a diminished clinical skills, especially bedside skills in current generation. In 1950s and 70s, till 1970s we can say, there is no radiology in most parts of India, except at few centers we were having a chest x-ray. So in those days we used to discuss, especially heard from our professors, that timing of the cough, resonance of the cough, characteristics of the cough are very important as far as interpretation is concerned. But as science advances, we realize that most of these things are not important. 99% of cough, they are worse on lying down. Second one is they improve with sleep. So that's it. Except in very few settings, if a person coughs because of cold air, it can be typical of asthma. So except one or two exceptions, nowadays characteristics describing the cough, its resonance, timing, all these things are not important. Only important were duration of the cough, any associated features. So that associated features we are discussing. One is thorough ENT examination. Because this vagus nerve, which we have been discussing, it has got branch in the auditory canal. In your anatomy textbook, it was mentioned as Arnold's nerve, ARNOLD, Arnold's nerve. So any irritation in the auditory canal might be because of the ASOM or CSOM, or because of foreign body like insects, kind of those things. They can stimulate the vagus nerve and can produce the cough. So cough is not essentially means pathognomonic of respiratory system. So anything in ENT, nose also. Okay. So what are those things you have to examine? Any secretions, any hypertrophic turbinates, even any foreign bodies, and nasal congestion, polyps, these things you can examine it nasal speculum. And last one is ask the patient to open mouth widely and say ah, Telugu ah, if possible, and flash your torchlight. So you can come across those beautiful adenoids and enlarged tonsils sometimes, or sometimes injected posterior pharyngeal wall, suggestive of postnasal drip, especially after episode of sinusitis. So ENT examination is must for examining ear, nose, throat, and sinuses. Also examine for sinuses like pressing over maxillary sinuses, our frontal sinuses, ethmoidal sinuses, which are palpable, and notice any tenderness. Okay. So in physical examination, you are going to do ENT part. Next one is look for any lymph nodes, either cervical lymph nodes, axillary, or inguinal lymph nodes. If you see lymph nodes, what you have to suspect other than tuberculosis, especially in young person, if they are non-tender, rubber in constituency. I am giving you a clue. That is lymphoma, Hodgkin's lymphoma. So Hodgkin's lymphoma can lead to cough, that you have to remember. Because of the enlargement of lymph nodes, they might be compressing upon the lung structures. And second thing is that innate microenvironment of the lymph nodes because of release of cytokines. So a person who is having a lymphadenopathy presenting with cough, you have to keep these differentials in mind. Tuberculosis, most common in our country. Second one is another entity closely related to that thing, but non-caseating granuloma, that is sarcoidosis. Third one is, you can remember at least Hodgkin's lymphoma. Of course, there is vast differential diagnosis that you can read in usual practical textbooks. These three are very important. Never forget Hodgkin's lymphoma. Okay. Second one which you are going to look for is skin and its appendages. So in skin especially, you are going to see nails, nail beds. So assess for clubbing. So what is clubbing? Clubbing is nothing but it is very simple. It is physiological response to chronic hypoxia, enlargement of soft tissues, especially around phalanges. Because this hypoxia can induce a lot of cytokines, especially because of transcription factors. Hypoxia induces transcription factors. Downstream, they are going to stimulate cytokines. So they can lead to enlargement of soft tissues with the deposition of collagen and also hyaluronic acid like glycosaminoglycans. So if you are seeing clubbing in the setting of cough, you have to suspect chronic etiology. So any inflammation can lead to clubbing. So clubbing is suggestive of chronic cough. Okay. It can happen in tuberculosis, lymphomas, cancers that we are going to discuss. That is known as hypertrophic osteoarthropathy. Enlargement of distal diaphysis. Distal diaphysis, not metaphysis or epiphysis. Distal diaphysis of long bones. That is known as hypertrophic osteoarthropathy. Okay. So other things what we had to look as far as skin examination is concerned. Just now we had discussed clubbing. Second one is look for any cutaneous changes, especially related to vasculitis. It is very simple. Vasculitis, earlier also I had told, inflammation of the vessels. So where inflammation of vessels can happen? Mostly in inflammatory diseases or autoimmune diseases. Earlier we used to call it as one of the entities known as vaginous granulomatosis. Nowadays term has been changed to polyangiitis with granulomatosis, just for confusing others. Or others won't remain same. Sometimes they have to describe themselves. They are also working also just by changing terminologies now and then, once in 5 years or 10 years. It's okay. Sometimes concepts do change. Accordingly, names also change, especially microbiology. Okay. Leave that burden to them, those specialists, for changing names. But current terminology is granulomatosis with polyangiitis. Another things what we have to see as far as skin examination are concerned. Any other diseases related to chronic cough, not only sarcoidosis. Other autoimmune diseases like systemic lupus erythematosus. There you can see a lot of skin lesions like heliotrope rash, butterfly rash, kind of those things. Dermatomyositis. It's okay. As far as current topic is concerned, our discussion is limited to chronic cough. So far, is it clear? History and physical examination. I repeat again, they are very important. As long as we are not applying what we have read to the patient, we are never going to be successful in our career. So after physical examination, what we have to do? There are two ways. One is chest X-ray. Most often it is PA view if the patient is mobile, or if patient is bedbound, APV only we can take. Sometimes lateral view also, depending upon the whims and fancies of professor and radiologist. Other thing what I have to do is sputum examination. Sputum examination is one of the very important. If the patient is expectorating, it is straightforward. And look for any contamination with the oral cavity secretions. That is pathologist headache. So assess the cytology, especially for malignant cells or atypical cells. In the setting of typical community acquired pneumonia or hospital acquired pneumonias, we are going to stain either with a classical gram stain or other specialist stains like AFB stain, kind of those things in our country. Second one is sending for cultures depending upon the clinical picture. But notoriously for mycobacteria, it will take lot of time, months together. Sometimes they may not grow at all also. So nowadays we are employing this multiplex PCRs. NA is nothing but nucleic acid amplification tests. That's it. Nucleic acid amplification tests. So these are rapid bedside tests that can give output within 1 or 2 days, aiding in the diagnosis and patient recovery. So these are the things nowadays we are doing depending upon the clinical scenario. Okay. Now we are at the junction. We have got a radiograph, we have got sputum cytology. Still the patient is having cough. Nothing was found out. Then what we have to do? So this is the way to approach a patient with chronic cough. That means for more than 2 months duration. Let's go to next slide. Till 30 years ago, there were hardly 5 differential diagnoses for chronic cough. First one was ACE inhibitors, asthma, GERD, kind of those things. But with advent of modern science and as our clinical knowledge got expanded, we came to know two varieties. That is hypersensitivity cough. Second one is upper airway related cough. These are two different entities. Most common are copper hypersensitivity syndrome, especially it is happening, we can call it as a disease of modern era or industrialization, where previously humans were not exposed to those noxious stimuli related to air pollution or other things they are doing related to human activities. So constantly these noxious substances. You remember those J receptors with their capsaicin? So through those channels, through those receptors, if they are constantly stimulated over a long time, in spite of absence of any insult. Insult means any viral infection or any environmental triggering factor, still the patient continues to suffer from cough. It can be continuous cough or intermittent cough. So those receptors, they become super sensitized and patient would continue to cough over months together. This is known as cough hypersensitivity syndrome most probably because of the air pollution. Second one is upper airway cough syndrome, UACS. Earlier it was assumed that one of the common causes of chronic cough is postnasal discharge. But nowadays there is a contention as far as the diagnosis is concerned. Why? Because in 90% of postnasal discharge cases, actually doctors have found out that there is no cough. That means they may not be related to each other, there might be some association. So they arrived at a term known as upper airway cough syndrome. Here, if you look closely at the pathology, what are upper airways? From the nose till the glottis. So nose, throat, inflammation anywhere here. If you examine, like what we have discussed earlier, polyps, discharges, either purulent discharges or serous otitis media, or throat, any swelling because of the irritant substances, or inflammation of lymphoid structures like adenoids, tonsils. They are constantly stimulating the upper airway nociceptors. So those irritating stimuli, when they stimulate these nasal cavities or throat through these nociceptors, they are going to travel in the same vagus nerve and going to stimulate cough. So in UX, upper airway syndrome, rule out ENT etiology. When ENT etiology has been ruled out, again same thing may happen. Long standing stimulation of nerves can lead to, just like what happens with neuropathy. For example, if a patient has got diabetic neuropathy, he will have burning tingling sensation of legs and feet. But over a period of time, what happens? In spite of control of blood glucose levels, still that pain may persist. This is nothing but adaptation of the body. Adaptation means in the absence of stimulus, still the abnormal trigger or abnormal sensation exists. So in the absence of trigger, if the abnormal sensation exists, just like neuropathic pain, here also the patient will have chronic cough, taking analogies. So we can call it as neuropathic cough. Neuropathic cough. That's why there is contention that you can use those anti-neuropathic agents, like what are they? Pregabalin, gabapentin, in the setting of chronic cough. Got the point? Okay, so it is clear. One is cough or one is cough hypersensitivity syndrome because of the environmental triggers, because of industrialization, whatever we call. Second one is upper airway cough syndromes. That means the nerves are getting super sensitized and they are going to transmit impulses even in the absence of trigger. So these are the now two most common etiologies of chronic cough, CHS and UACS. Here comes the classical description or etiologies of chronic cough with a normal chest radiograph. Drugs, most commonly ACE inhibitors, angiotensin converting enzyme inhibitors like ramipril, captopril, lisinopril. Second one is ENT related postnasal discharge that we have just discussed. Third one is, this is also contentional, that is from the GI tract. Gastro means stomach, esophageal reflux. Reflux means coming upwards, backwards, you can say disease or disorder. Gastroesophageal reflux, reflux up to even glottis also, disorder. So in settings of GERD, examination of glottis may reveal erythematous lesions of esophageal mucosa. So you have to suspect GERD in those settings. And one of the common suspected one is asthma. Asthma can be associated with normal radiograph. Remember the point? This is very, very important. Closely related to asthma is its variant that is known as eosinophilic bronchitis, where infiltration of eosinophils are limited up to large airways, but with no typical features of asthma, like wheezing, kind of those things that we are going to discuss. So let us discuss one by one. ACE inhibitors, what you commonly come across, ramipril, lisinopril, kind of those things. Here remember that the side effect of cough is not duration dependent or dose dependent. It can happen as soon as patient initiates the medication. After long time, say for years together, patient has been asymptomatic, not having any cough. Thereafter, he may develop this dry cough. Why it happens? Okay, let us erase this. You know this angiotensin converting enzyme, where it acts? It acts upon angiotensin 1 to 2 conversion. After that, 2 has got various mechanisms of action, like acting on its own receptor, causing sodium and water retention, and also stimulates aldosterone, kind of those things. Of course, it's okay, we will discuss them in fluid and electrolyte balance and also as far as endocrinology is concerned. So the function of angiotensin converting enzyme is conversion of angiotensin 1 to 2 that we have discussed. Second one is this enzyme controls, means it degrades tachykinins, like our substance P, which we have just discussed, which is the neurotransmitter for cough impulse, and also bradykinin. So this nociceptive substance bradykinin, which can lead to edematous mucosa, they can induce the cough. So whenever a patient is having chronic cough on ACE inhibitors, because there are good alternatives available like ARBs, angiotensin receptor blockers. That means this angiotensin 1, 2 has got one receptor which are downstream sodium and water retention that we have just discussed. So here in this setting, stop this ACE inhibitor like ramipril and initiate alternative one like angiotensin receptor like telmisartan or olmesartan, So after a period of 4 weeks, cough will be gone, no cough. So here we are selecting a drug off trial, means we are stopping the drug and assessing its prognosis. If it is really AC induced cough, means inhibitor cough, AC related cough, the patient should become symptom free at the end of 4 weeks. If not so, suspect other etiology. Okay, got the point? Second one is post nasal discharge. This already we had discussed when we are evaluating this upper airway cough syndrome. So most of thing it will be repetition. Do thorough ENT examination and treat accordingly. Similar thing applies for gastroesophageal reflux disease. Gastroesophageal reflux disease. It can be acid reflux or non-acid reflux. If we are seriously concerned about any reflux, refer to medical gastroenterologist. There they will do pH monitoring of esophagus for 24 hours. In addition, they will do manometry, means esophageal pressures, manometry, esophageal pressures. Accordingly, GERD would be diagnosed till what level reflux might be happening. At the level of glottis or even up to even pharynx also it is happening or not, they will evaluate. In addition, they may do upper GI endoscopy. So this is the domain of medical gastroenterologist. Coming to another important etiology of chronic cough with a normal radiograph, especially in children, is asthma. It is dubbed as cough variant, cough variant asthma, ASTHMA, where the child manifests only with a simple dry cough on exposure to cold air or in winter months. So what happens is that instead of classical symptoms of asthma, what are classical symptoms? Chest tightness, wheezing, kind of those things. The patient doesn't have all these things. Only simple dry cough would be there, nocturnal cough. So in such settings, if you are evaluating for asthma, look for response with inhaled corticosteroids or bronchodilators. So accordingly, you can evaluate for asthma, and also you can estimate asthma by measuring peak expiratory flow rate, PEFR, because nowadays they are ubiquitously available, means everywhere. So at home also they can monitor, and you can arrive at a diagnosis of asthma as far as chronic cough is concerned. Okay. So both diagnostic trial and therapeutic trial with beta 2 agonist you can give. Last one, actually it is a variant of eosinophilic infiltration, but limited to bronchitis without, again, no manifestations of asthma. This is known as eosinophilic bronchitis, where expectorant sputum should have at least 3% or more than that of eosinophils. Remember this thing, 3% or more than that of eosinophils of entire cells in the expectorated sputum. Okay. So eosinophilic bronchitis, because it is also one of the allergic manifestations, we would expect a good response to inhaled glucocorticoids. Inhaled glucocorticoid means topical glucocorticoids. Here the patient doesn't have asthma-like features, but will have chronic cough, that is for more than 2 months duration. Okay, clear? Now let's go to next slide. This is about treatment part. So far we have discussed the normal chest X-ray. So on normal chest X-ray, what treatment we have to give before embarking on doing other evaluation, especially with the CT scan kind of those things, means HRCT chest. You can give topical antihistamines or topical anticoagulants like ipratropium. Simple nasal saline irrigation in the setting of UX, upper airway cough syndromes, or even post-nasal drip also. So depending upon the etiology, give nasal decongestants, nasal glucocorticoids. So effectively they are going to relieve if it is not of serious etiology. Okay. There are many local antihistamines that you can read your pharmacology textbook. On other hand, in some settings, like in allergies, in asthma, we had to resort to giving antihistamines, systemic antihistamines like bilastine or antacids. Please remember, this is the treatment before embarking on HRCT chest. So with these simple measures, most of the causes of chronic cough should go away. That means HRCT test is not mandatory for each and every case of chronic cough. Okay. So in such settings, you can give antihistamines like bilastine or loratadine or dexloratadine, or in suspected case of gastroesophageal reflux disease GERD, you can give proton pump inhibitors, H2 receptor blockers, or you can give sodium alginate, which decreases the erectations. Okay. Sometimes even simple head and elevation while sleeping or while recumbent, that would help. Means at least at 30 degrees to 45 degrees angle, and not lying down immediately after meals. Okay. These are all the simple measures patient can adopt in his lifestyle. Coming to other side, where we have got diagnosed things which may not require HRCT test, like asthma. There you can give inhaled glucocorticoids, beta 2 agonists, that we are going to discuss in next session. On other hand, if the patient is having a chronic cough where there is no serious etiology, give opioid, or you can say mild opioid like dextromethorphan, though it is not as effective as codeine or morphine. To some extent, it is cough suppressant. Nowadays, there is research activities going on, opioid receptor antagonists and also opioid-like receptor antagonists. So in future, new drugs may come in this horizon. Okay. Second one is benzonatate. This benzonatate acts at the peripheral nociceptors, C fibers, numb them. So it also can be used, but it has to be taken multiple times in a day. And another interest, as we had discussed previously, like neuropathic cough, because similar manifestation is happening, there is interest in usage of gabapentinoids like pregabalin. Okay. These are all one can utilize in a setting of chronic cough where we don't suspect serious etiologies. Okay. In spite of all these things, if the patient is still having cough, what we have to suspect? Then we have to definitely look for systemic diseases. What are they? Interstitial lung diseases, any malignancies, autoimmune diseases like SLE, or sometimes tuberculosis or fungal diseases. So all these things you have to suspect, and in such settings you can go ahead with CT chest. Okay. There is one reassuring point. In a patient with chronic cough, with all these investigations normal, means spirometry, initial test what I have done, sputum examination, thorough ENT examination, normal radiograph, and normal CT chest, there is very remote possibility of serious disease. Just assure the patient. Okay. Clear? Let's go to last slide. So what are other agents which are used in chronic cough? This slide is a bit advanced. It might be useful for those who are appearing for USMLE or those who are doing post-graduation either internal medicine or pulmonology, where there is interest in novel agents as far as cough is concerned. Now we are clear about our pathobiology or pathophysiology of cough. Okay, there are so many receptors, so many channels involved. First one is our neurokinin 1, that is receptor for substance P, which is at substance P, which is at spinal cord and upper levels. So there neurokinin 1 receptor, these mediate the central action of substance P, traversing towards our cough center. Have you come across these agents in any other settings? Because most of our vital functions, respiration, swallowing, digestion, thermoregulation, okay, other than hypothalamus, they are all vitally in our medulla oblongata. They are located in our medulla oblongata. So these agents you might have come across in the setting of treatment for vomitings, especially related to chemotherapy. Because chemotherapy nowadays, because of our longevity, we are having more number of cancers and they are being treated with various regimens like chemotherapies, immunotherapies, not only radiation, surgery kind of those things. Especially related to chemotherapy, there is a very high incidence of vomitings, especially related to few agents. They are known as highly hematogenic chemotherapies. In such settings, we use dual, triple combinations also, like serotonin receptor antagonist, like usual ondansetron, palinosetron kind of those things. Because there are two phases in that, acute phase and delayed phase. Especially in delayed phase, there is a role for these NK1 receptor antagonists. So you might have come across usage of these agents in combination with the serotonin receptor antagonists in the treatment of chemotherapy. These are very long acting agents. Netopitant, first one is apripitant, rolapitant. These are longer acting ones, means for weeks together. They are given as preemptive therapy for chemotherapy induced nausea and vomiting. Okay, so they have got a role in the suppression of chronic cough also, because all these centers, vomiting center, respiratory center, are located especially that around nucleus tractus solitarius in the medulla. Second one is TRPV1 channel that we had discussed earlier. This is the peripheral channel for our substance P. Our scientists have tried various agents, but unfortunately what happened is that this TRP1 channel is also related with body thermoregulation, means control of our body temperature by dissipation, kind of those things. If you are blocking these channels, patient may be prone for hyperpyrexia. So clinical trials that have been done have been stopped because of fear of hyperpyrexia. Okay. So next, what lies in our store as far as the near future is concerned, that is purine related channels that were discussed in first slide, P2X3. The antagonism at that channel can aid in the treatment of chronic cough. On one hand, we are giving these agents, on the other hand, we are aiding these agents. That means with a dual action, we can suppress the chronic cough. So what are those agents available in pipeline? Eliapixant. Second one is Sevofixant. Of course, they are not in the market, they are in research trials. The importance of this slide is because chronic cough modality is still evolving domain. The drugs at present are modestly effective. That's why we are searching for such agents. On the other hand, those agents which are not available in few developed countries like United States but available in India, I have listed on right hand side. These two are very commonly prescribed in our practice. So now we will discuss those agents which are available in our country. One is Levo, levoisomer of chlorpyrrostine. Second one is levodropygen. Levodropygen has got peripheral action. So at the level of nociceptors, that is, we have seen TRPV, second one is P2X3 channels. These are at J receptors. Substance P goes through C fibers towards our central structures. So levodropygen acts at the C fiber, this means unmyelinated fibers, and it numbs the propagation of nerve impulse because of substance P. So if you are seeing prescription of levodropygen, it is meant for peripheral antitussive action, means there is no risk of sedation here. Because it is acting peripherally, there is no risk of sedation. That's why in India we are seeing the prescription of levodropygen. Coming to levochlorpyrrostine, more commonly prescribed one, it has got dual mechanism of action. One is central, second one is peripheral. Let us discuss peripheral. It is not classical antihistamine but still acts on histamine receptors, which are situated on the same C fibers. So nerve impulse propagation is inhibited. Second one is it has got antispasmodic action like papaverine compounds. So bronchial muscle is relaxed. That's why patient gets relief. Antispasmodic. Third one is again serotonin antagonism. So it has got triple peripheral action: antihistamine, anti-serotonin, and antispasmodic. So clear? Coming to central mechanism of action, it again acts at respiratory center, but not through those opioid receptors. That means it is non-sedative. But central mechanism of action is to these sigma-1 receptors. Sigma-1 receptors at medulla oblongata. Second one is G protein coupled inward rectifying, IR means inward rectifying potassium channels. So these two channels are located at the same site of opioid receptors at medulla oblongata. By its non-opioid action, that is again I am stressing upon sigma-1 receptor antagonism and G protein coupled GIKR, G protein coupled inward rectifying potassium channel receptor. By inhibiting these things, it has got antitussive action. Okay. So to summarize, levodropygen has got only peripheral action, whereas levochlorpyrrostine has got dual mechanism of action. One is central and second one is peripheral. So with this slide, we have completed the discussion of cough, especially chronic cough, its etiologies and how to evaluate, and those things especially one shouldn't miss. Okay. If you have got any doubts, please drop a comment or let me know. Accordingly, we can discuss. Thank you very much.